So good morning, everyone. It's a great pleasure to welcome all of you for this I3h seminar that will be given today by Professor Sandy TUBEUF. So we are really very happy, Sandy, to welcome you today. As you know, it's a special day because we have a new great announcement of still another vaccine which proved to be quite efficient. So I think that the topic that you will cover is really timely. So just to introduce you briefly, Sandy TUBEUF is Professor of Health Economics at the UCLouvain, and she's also visiting professor at the University of Leeds in the UK. And the career of Sandy is quite interesting. She's really, I should say, an international researcher. I cannot say really European anymore, since you spent some time at the University of Leeds, at the University of York, but also in Paris at the Institute of Research in Health Economics. Your research is primarily focused on inequality in health and inequalities of opportunities. You have expertise in policy evaluation methods and analysis of large data using applied health econometrics. So we know each other together with Mathias de Watripon since some time now, and we really appreciate the work you are doing at UCLouvain, where you have, I think, a double affiliation in health and society and also health economics. And I think that the work you are doing is, I think, quite well known now by the lay audience. You have been quite visible in Belgian media, and I'm sure this will continue since you are now spending some time in looking at important questions related to the COVID-19 pandemics, and more recently on the way we will hopefully overcome the pandemic through vaccine campaigns. And your topic today is exactly on that. The title of your talk is "Who Should Get It First?", which means which are the public preferences for prioritizing a COVID-19 vaccine. Sandy, thank you very much again for being with us today, and the floor is yours.
Thanks a lot, Michel. Thank you for the invitation. I'm really pleased to present this research work. So I was supposed actually to give a seminar earlier in June, and so then we changed our plans because of the pandemic and various things. And now I'm here and I'm presenting some very recent work that we've been doing with two of my colleagues, Jeroen Leuten, who is at TUBEUF and who is as well a health economist, and Rosalind Kessels, who is based in Maastricht University. And Rosalind is a statistician, more econometrician, and she has a strong expertise in the methods we're using for this paper. So without further ado, let me just start. Oh, can I move it up? Yes. So we all know, and actually that's really, to put a bit of context, which I think most of you are very much aware at the moment, that at the moment we're talking a lot about vaccine candidates becoming effective and quite, attractively soon, being able to vaccinate people for COVID-19. But having good news on a vaccine being soon actually effective, there are new challenges that could come for us. First of all, we all know that the production will take a bit of time. There will be some logistic and aspects will be quite limited. And actually, there is as well a very large demand. We know we're facing a global pandemic. So there will be questions about how to distribute those first units of vaccines, first of all, across nations, as well as within nations. And all these kind of choices that are inevitable, are really about how could we distribute those first vaccines within the population. So here we're really interested into, taking for granted the fact that actually not everybody that could benefit from the vaccine will be able to have it straight away, and there will be some choices to be made. So that decision on how and who should get priority to the first doses is currently being debated. There are plenty of articles that have been published, in the news and as well as reports, where there is this global acknowledgement that we need to put in place some allocation strategies and to be prepared actually of the soon, available vaccines. Lines that have been published. So the WHO has published through their strategic committee a strategy where they identify the groups that should be prioritized first. The NASEM in the US has also published its own list, and the usual, Centers for Disease Control and Prevention in the US has also published it, the European Commission. And at the moment, a lot of different national governments are also talking, in terms of list and number of identified subgroups. And so what do we find mainly when we're looking at most of the documents is that actually they kind of have a consensus on these vaccines. First of all, the frontline health workers are very important. Of course, we know that actually they are there helping with caring for patients with COVID. So they're really targeted first with potential vaccines. Then, of course, there are the people that could benefit from the vaccine, which are those that are at higher risk with COVID. So either higher risk of difficult forms of COVID or even dying from COVID. Then actually, we also have people with essential works that have been identified as priority. And people living in crowded settings with higher risk environment also being those that actually have been identified primary needed. So while actually the World Health Organization and the European Commission guidelines explicitly identify subgroups, when they state them, they make the choice of saying that actually they won't be ranking those groups. They will just consider all of them without ranking them in order of priority. On the other hand, NASEM in the US has suggested more of a phased, a vaccine allocation where they're guiding the priority list with a risk-based criteria. So I'm reproducing here the table they had in their report, where they were actually looking into what they called a tiered approach with several phases with vaccination. While in phase 1, they would focus on healthcare workers. Then actually they will look into people with underlying condition. And then they will actually look into more other essential types of workers and increasing actually the number of people being vaccinated and so on until everybody is vaccinated. The interesting thing here with the strategy that NASEM is putting in place is that actually they're taking into account the size of the population that actually are targeted in each of those phases. But if the World Health Organization, the European Commission have decided not to put any ranking, while NASEM did, there is de facto a need to put a ranking within those groups, taking into account the fact that actually the supply will be restricted in the first place. So what it is about this paper that I'm presenting today. So at the moment, most of the vaccine allocation strategies that are being discussed have been based on experts' opinion. But actually, we thought that the population may have different views on who should get the vaccine first. And so what I will present today is a research work where we had two objectives. The first one was to investigate how the general public thinks about the different plausible allocation strategies that are being discussed at the moment for COVID-19 vaccination. And then to study further the preferences when asking them actually whom they would vaccinate with concrete individuals that would be competing for a vaccine. So why does the view of the public matter? That's actually the main question here. Do we think that actually we should ask people what they think about allocations of vaccines? So I spent quite a lot of time in my career in the UK, and there is actually more and more importance given to what they call PPI, the public and patient involvement. And when you're looking into healthcare decision making, the PPI is more and more encouraged. And PPI in public decisions is particularly important when we're facing situations where there are large stakes and substantial ethical components, where we think that actually we need to get towards decision making for healthcare that is a bit more democratic. About the COVID by itself, we know how actually this pandemic is a major collective crisis. And so PPI has already been quite instrumental in some of the successes that we've been, seeing for this pandemic. Physical distancing was asking actually involvement of the population. Similarly, wearing face masks, accepting lockdown is also demonstrating that actually to be effective, the battle against COVID needs actually the public to be accepting the policies that we are putting in place. If we're now thinking about the COVID vaccine campaign, it will also need some public trust and goodwill from the population to adhere with the strategy that I put in place. So the idea here of this work is really trying to identify what are the mechanisms when allocating vaccines that would be the most acceptable, considered the most fair by the population. So what did we do? We ran actually a survey. We were actually looking into a representative sample of Belgians. So we tried to have actually a sample that was representative on age groups, gender, education level, and regions in Belgium. So we collected our data over 2 weeks early in October. And so our experiment worked in 2 stages. In stage 1, we were presenting people with an opportunity to rank some alternative strategies for vaccination that I will present in a minute. And in a stage 2, we used actually a method that is quite known in economics that is called a discrete choice experiment. I will come back and explain what it is, how does this thing work. But just to make sure that actually you know what we're doing here is that actually the respondents were told 2 things. First, that the vaccine was equally safe and effective in all people. And then we asked them to think about what would be, according to them, the best allocation for society as a whole, and not in their own self-interest, really what they thought would be valuable by the population or for the population. The survey also collected a range of socio-demographic characteristics with various other data that could be useful to us. We, for example, knew about their financial situation, their health status. We also asked themselves about their own experience with COVID, for close network. We knew whether they belonged part of a risk group for COVID. We had as well information on the attitude towards vaccination and towards vaccination for COVID itself, as well as towards the way the government had been dealing with COVID. And at the very end, we were also asking them their opinion about whom should be deciding how we allocate the vaccine. So these are a number of characteristics that we wanted to collect, so then we could explain a bit more the results that we would find. So let me talk now about the first part of the experiment, which is this ranking exercise. So we considered 8 alternative strategies to distribute the COVID-19 vaccines. And the respondents were asked to rank them from the one that they thought would be the most appropriate strategy to the one that they would think is the least appropriate strategy. And so among those 8 strategies, 5 of them were actually focusing on population subgroups. And I will detail a little bit more, but so that you know, those 5 groups globally were the chronically ill, the elderly, the virus spreaders, the workers, and the essential profession. I will detail a little bit more in my next slides what they look like, how actually people were presented with them. And then we looked into 3 other strategies that are not directly population groups, but that are considered when you are in a context where you're trying to distribute a scarce resource. And this includes a lottery, a first come, first served a first served approach and a market approach. But again, I will detail this a little bit more in the next slides. So 5 groups. So here is the table actually we have in the paper, but instead of having a table, they were represented for each new screen. They had a presentation of each group. So let's look here, for example, at the prioritizing spreaders. So what we were saying to respondents was, we could first give the vaccine to the people who spread the virus the most because they have a lot of social contacts in their daily life, at work, at school, in the neighborhood, in public transport, etc. These people themselves are not at high risk of serious illness or death from COVID-19, but they can infect many others. By vaccinating them, we would slow down the spread of the virus as much as possible. So you see, we were not directly saying who we're thinking about, but we were trying to put respondent within the context of understanding what does it mean to prioritize spreaders of the virus. Similarly, prioritizing workers, what were we saying? We're just saying people who work will cause a greater economic cost when they become ill than those who do not work. By first vaccinating working people, we would ensure that the virus does as little further damage as possible to the economy. So we're just really presenting globally the different strategies we had in mind without actually saying here how many people would be, for example, affected by having the vaccine. Talking about essential professions, we know that actually most of the strategies that have been identified have really been about healthcare workers. In our study, what we were saying about that strategy was that some professions are more essential to society than others. During the pandemic, health workers, hospital staff, police, and garbage services had to continue working as usual, while others had to work from home or were temporarily unemployed. By prioritizing workers from these vital sectors, we would protect the normal functioning of society. So here again, we're not targeting really one type of work, but we were naming here all the professions that had been recognized as being essentials. So people responding to our survey were actually presented with all those different strategies and really understanding a bit more what we meant by them. As I said, there were another 3 strategies that we suggested among the 8. And one of them is a lottery. So what is the lottery? Why would we distribute actually a good in a lottery? When actually we're looking into providing people with the same chance here to be vaccinated, then we could distribute a vaccine randomly among the population. And this actually would be given to people regardless of their health risk or the social impact that an infection could have on them or on the society. Another way of distributing a limited good could be actually to say that there is a distribution where the population is served according to the principle first come, first served aspects. So that would mean that people who present themselves the fastest for vaccination at the doctor, at the pharmacy, or to any services of the government would be given priority from the moment that there is a vaccine. And finally, another 3rd way that has already been seen in other distribution of scarce resources is the market. And how the market would work, it would mean actually that here we would sell, for example, the available vaccines to the highest bidders. And so that would be the people who want to pay the most money for a vaccine that would be given priority. So we presented all those 8 strategies to the respondent to our survey, and we asked them to rank those strategies one after the other from the most appropriate one, according to them, to the least appropriate one. So I'll present the result after, but let me now present the stage 2 of the experiment. So the stage 2 is what we call the discrete choice experiment. And discrete choice experiments are methods that are quite used in economics, in choices, not only in health choices, but many other type of choices that people are making at any time in their life. And this kind of methods is mainly there to elicit individual preferences, understand how to attribute elements or goods. So in a nutshell, this kind of methods, participants are presented with a series of choice sets between usually two types of good or two types of services. And the two services are described by the same attributes. And the only difference is that they will have different levels on those attributes. And the idea is that by observing a large number of choices, then researchers are able actually to understand what do people value. And, oops, sorry, what do people value? And so what we have here is that the discrete choice experiment is forcing choices, is forcing individuals to choose who they would vaccinate between two hypothetical candidates for the COVID-19 vaccine. So, next slide. So what did we have here? We had actually to think about our candidates to vaccination and to describe them according to some relevant attributes. And so we based those relevant attributes to the 5 most relevant attributes that actually were defined for groups, subgroups that would be vaccinated. The first one being the age characteristics, so knowing whether an individual is 60-year-old and over or is below 60. Whether the individual belongs to a medically vulnerable group because he has comorbidities, whether the individual would cost something to the economy if he is infected. And so here we considered 3 different attributes, costing €0 a day, €100 a day, or €1,000 a day. Then the 4th characteristics was whether the individual was having a profession that we could consider as being essential. And finally, whether actually the individual would be a high spreader of the virus or a low spreader of the virus, and being actually on average infecting 1 person or 10 other people. So the way that actually we could easily and robustly make our conclusion was actually to look into those 5 attributes, but keeping 2 levels as constant. So 2 levels being exactly the same between the 2 individuals and only them varying over 3 levels. So let me present here what it did look like in the survey. So you have here exactly what the individuals were presented with. We were asking them to choose between person A and person B, which one they would vaccinate first with the new COVID-19 vaccine. What we have here, for example, is that person A is actually a person with a high risk because he has a chronic disease. We know that he is younger than 60-year-old. We know that he would infect 1 other person in case he is himself infected. And then it costs the society €100 and his profession is not essential. If we're looking at person B also would cost society €100 per day and also doesn't have a profession that is essential. But person B changes from person B, from person A on 3 characteristics. This one has no comorbidities, so no underlying condition, is more than 60-year-old, and if infected, it would infect 10%. And so the individuals in our survey had to decide which one of the 2 individuals here would actually get priority to the vaccine. So the complete design of our discrete choice experiment here consisted in a total of 30 choice sets that we splitted into 10 choice sets. And so we made sure that actually we had a representative sample of respondents that actually completed each of those 10 choice sets. And so within each of the surveys, what we did is that the 10 choice sets were presented in a random order. So then we could counteract any possible order effects in their answers. And what we also did, it was actually, we presented people just before they did the whole experiment with actually a mock choice set. So then, we could try to let them let's say, dry run a question, see whether they understood it. But that actually mock choice set was the same one as the very last one they had in the analysis. So the way that actually worked, that our study worked, is that we had pairs of choices that were presented on 1,944 respondents. This is the final analysis, what we used. So we had almost 20,000 pairs of choices between hypothetical individuals competing for vaccination that we analyzed. So the statistical way to analyze this kind of data is to use a panel mixed logit model. And then we were using all the data that we collected about the individuals, in fact, to try to see how actually they were differing in those type of covariates using bivariate analysis. And then we also did multiple analysis where we were putting together a large set of covariates to see how they differed in their answers. So in terms of results, so the survey on average took about 21 minutes for individuals to complete, and most of them have actually found it easy. 56% found it easy, and 43% found it difficult but doable. So we had very few of them actually finding it too difficult. And what we had here is that about 40% of the respondents told us that they were part of a risk group, and a small minority of them had actually a COVID infection, either for themselves or in people around them. But let's show you now here the ranking exercise. So this little graph is summarizing really the first stage of our experiment. What can we see here? Here we're ranking from rank 1 to rank 8, the position that were given to the 8 different strategies we had. So if I'm looking here, we can see that actually we have 3 curves, mainly on the really left-hand side, 2 curves roughly in the middle, and 3 curves at the bottom. So looking a little bit further into them, we have here in blue the chronically sick individuals. Orange is the essential profession, and red is the elderly. What does it mean? It means that actually roughly between 20 and 30% of the time, each of those strategies are being ranked as the first favorite one. Then here, this is how they ranked as the second favorite one. Here is the third favorite one. So these are what we call cumulative distributive function. And so according to this cumulative distributive function, there is a preference for ranking in the beginning of the ranking of priorities, the chronically sick, the essential profession, and the elderly. So the population seems to have a consensus for 3 priority group of importance. There is not one favorite one. Then we find in the middle strategies that actually are quite attractive, but more around, let's say, ranking at the 4th favorite one and the 5th working people. And then at the bottom right here, so these are the strategies that are less popular in the population, those that actually are most of the time ranked as 6th, 7th, or 8th, so where we have the largest group of the population ranking them. And these are our 3 strategies, the one for the lottery, the one that is first come, first served basis, and the highest bidder. What I want to just to flag up here is that if we look here, we still have a 10% of the population that seems actually to be quite keen to give the vaccine on a lottery basis. So I will come back to this now. So what we have here, just you bear in mind this graph, is that there seems to be 3 groups that really seems to matter as being priority for vaccination: chronically sick, essential profession, and elderly. And there is a little 10% that actually would not say no to a lottery. So let me tell you a little bit more on those 10% of the population, because we're quite intrigued to know who were those respondents ranking lottery strategy as the most or the second most appropriate strategy. actually younger respondents with a problem, more French speaking, and not belonging to a medical vulnerable group. We also found here people that actually were more likely to think vaccination is useless and not likely to vaccinate themselves with the COVID, and saying they were dissatisfied with the government policy towards dealing with the corona crisis. And we had here individuals that were more likely to think that vaccine allocation should be driven by the preferences of the population instead of the preferences of policymakers. So this very small 10%. Then we had the discrete choice experiment. And these are the results of the discrete choice experiment. So here I want to flag up the 3 groups that seems actually to get the higher position in terms of priority for the population. And so what do we have here is that actually our sample seems to be keen to vaccinate people with medical risk, people that are virus spreaders, and people that are from an essential profession. So as soon as we gave slightly more information on what it meant to be a virus spreader or what it meant to cost more to society, there is actually more willingness to vaccinate those 3 groups. Or whether, something that is really interesting here in our result is to look at the standard deviations. And they are quite large. What does it mean if the standard deviations of the other priority group are quite large? It means that actually we have a high heterogeneity in our results. So understanding really what are those 3 priority groups and how actually they spread in the population. On the blue graph here on my left-hand side, you have the full sample results. And so we can see if the bar is larger, it means that actually that characteristics is given more importance. So we can see that over the full sample, there is more importance given to medical risk group, to being a virus spreader, or to have an essential profession. On the right-hand side, being bigger means actually that people are more likely to vaccinate, and on the left-hand side, less likely to position them. So what we have is actually those 3 groups of importance. But what is really interesting, if we try to look further into how this full sample separates into clusters, we would have actually a cluster 1 where the medical risk group doesn't seem to matter that much, and it's roughly 50% of the sample, but they value a lot vaccinating the spreaders. And then they give some importance to essential professions. We have a second cluster here, which is the other half of the sample, where they give more importance to vaccinate first the medical risk group, so people with a medical risk, then the essential profession, and then later on virus spreaders, all the people. So what could we see here? We could see that actually we had two groups, and that in those groups, in fact, the aspects related to age or related to being costly to the society was of a lesser importance. So the membership of each of those clusters was explored a little bit further with the characteristic we had. And so in the cluster 1, where we had actually people vaccinating more spreaders, and cluster 2, where we had actually people more likely to prioritize people with clinical or pre-existing conditions, we found that the respondent from that cluster 2, so the one prioritizing vulnerable groups, were people that were more likely to accept being vaccinated for COVID, less likely to think that COVID-19 vaccine strategies should be made by the population, more likely to think that the government should make those kind of decisions, and less likely to be French speaking. However, we found it very interesting that there were no relationship between being member of a cluster, the cluster 1, the group 1, or the group 2, the clusters here, in relation with the respondent age, or whether the respondent had themselves an essential profession, or a certain level of financial difficulties, or education, and any other variables. So it was actually quite interesting to see that the respondent choices in the discrete choice modeling was not driven by their self-interest. So let me summarize our results here. We found that actually the strategies where groups were defined at a policy level were most supported by the population. We had very little support for the libertarian-inspired strategies, like the market-based or the first-come, first-served basis, or even for the egalitarian approach, except for a little 10% of the population. When we were asking people to rank overall different vaccine allocation strategies, it looks like the representative sample of Belgians here is prioritizing the similar groups that those that have been chosen at the moment as being priority by the governments and by the expert groups, which is the essential workers and the old and the ill people that are at higher risk of severe COVID and death. But when we asked to make further choices between hypothetical individuals, and when we were providing the respondent with specific values of what being a high virus spreader or being more costly to the society meant, we found that these societal preferences started leaning towards upgrading the high virus spreaders as a priority group and remaining with the medical vulnerable group and the essential profession as being important. And so here in the DCE, in the discrete choice experiment, it appears that the public would not prioritize as first priority group, neither the people older than 60 or the people that actually are of particular economic importance to the society. So what is really interesting in the discrete choice experiment is that we could see really the population being divided in two clusters. One cluster where they would maximize the societal health outcomes with the vaccination strategies. So what we would put in first, the individuals that needs it because of their health status. And we have another group where actually their favorite first strategy, the first one is the utilitarian one is trying to focus on the virus spreaders. So trying to increase the number of people that actually could be vaccinated and reducing the number of contagion in the population. So this is the utilitarian strategy. And then we have another cluster, another group of the population, the other half, where they want to be more prioritarian. They think that the way the strategy for vaccination should be put forward is first targeting the medically people, the people that are the most medically vulnerable and that need actually to be vaccinated because they would benefit from it from their two strategies here, one that is highest risk, one that is utilitarian towards the virus spreaders. And then the second group of importance for those two clusters is the same one. It's essential professions. So essential profession would be of a secondary importance, but still very high in the ranking. So how relevant is this research for the current debate? How can we use this? So ranking is definitely not straightforward. I was starting by saying that the WHO and the European Commission had decided not to rank their priority group population. There is not a consensus. So we have in a way always 3 or 2 strategies, but we don't have one favorite one. And so there is really a difficulty here to actually prioritize one single group. But relative to other key subgroups, an interesting result from our study is that there is a preference for not prioritizing older people in the first place. This research is quite important because we value the public opinion in such collective debate. And another very interesting result of our study is that actually when we asked the participants, who, according to them, should be in charge of determining the priority group for vaccination, 78% of our respondents decided that it would be scientists to decide, and very few of them thought that actually this was a decision for the population. Obviously, there is a very interesting element here that actually we didn't look into, which is that allocation strategy for vaccine will not only depend on the priority group definition, but also on the vaccine properties. And we know that some of the vaccines might be more appropriate for primary protection or for secondary protection. Some may have very specific efficacy characteristics, meaning that actually it's not only about priority group, but could also be about the priorities of the vaccine that are available. So I thank you very much for listening. The full paper of this study is available in CEPR COVID Economics issue 57, and you can find it online with this web link. Thanks a lot.
Michelle, you are on mute.
So Sandy, thank you so much. It's difficult to applaud through Zoom, but I'm sure that we would like to do so. I think that was really a great talk. So I take the privilege of being the moderator to ask the first question, which might look, wow, quite critical, but I think it's important. And actually, you alluded to this on your last slide. The major problem I have with this type of survey is that everything depends on the information that the people has about, you know, what we can expect from the vaccine. And I think that it's quite complicated to get information about preferences around allocation if we are not sure that people understand what we might expect from vaccines at this stage. And for me, there is a confusion there because so far what we can say quite safely is that we will protect vulnerable population from the more severe forms of the disease. This is, and again in the AstraZeneca trial published this morning, that was very clear. There was, I think, not a single case of severe disease in the vaccinees group. So that's a fact. Regarding the ability of the vaccines to prevent really infection and transmission, this is really unclear at this time point. And actually, if you look, for example, at a very interesting statements by Marie-Paul Kenny, who is probably one of the best specialists about this, the idea might be indeed that we will end up with vaccine to a situation which might be quite similar to what we know with flu. So the virus will circulate. It will cause mild disease in most people, perhaps still a few cases of severe disease, but without a major impact on our health system. This is at least a scenario. And the scenario to have the virus completely disappearing is really unlikely. Actually, we have only one example with smallpox about vaccine completely eradicating the virus. So what we might expect is really an impact on the disease itself. So again, we might indeed expect that the vaccine will have some effect on the spreading of the virus. And, you know, I understand that the idea to prevent virus transmission through super spreading is a concern. But I still think that, especially once in the future, when limited doses will be available, the main purpose would be to prevent the most severe cases, which is important for the people themselves and also for our hospital capacities. Now, and I will come to my question in a moment after my comment. My second comment is that I'm really wondering when they say scientists should take the decisions, what do we include in scientists? Because there are many types of scientists. And I'm a bit surprised not to see more a role for general practitioners. And as a physician, I really think, and I would recommend, and I actually recommend to people coming to me, discuss with your GP. Because, you know, each individual is different and might benefit differently and might need a different type of vaccine. So I think it's really important to really make sure that first-line doctors are involved in the process. Now, my question is simple. Before asking the question in the survey, which type of information did your people get? Do you have any idea what was the status of their knowledge level about what we can expect from vaccines?
Thank you, Michel. I think most of the thing you said, it's true. And you were right in the very first part of your comment where you were saying there are many other characteristics. And so we were doing a trade-off here, you know, by not giving too much information and assuming that this vaccine would be efficient in the same way for everyone in the population. But this is a limit, but actually we couldn't enter too much in that information. So now, actually, really about their understanding of the vaccines or their knowledge, let's say what you're asking is their literacy in vaccination. Yeah. No, we didn't ask any of this. We were more trying to understand their attitudes. So we did ask them whether actually they would vaccinate in general, whether they would vaccinate themselves for COVID-19 vaccine when that would be available, but we were not asking this. Then, as I said at the beginning, we have a representative sample regarding education level. So we do have here, you know, people that are highly educated and people that are not that educated. So we were able, if you want, you know, to control in the answers the level of education. But now we know as well that among the anti-vax, we don't have systematically people that are highly or poorly educated. It's quite spread. But no, we were not really. I think the study was really about trying to understand the choices that people would make with just the level of information of who those groups would be.
No, I think that's, let me be clear, I think that's very important. I would consider this as an important baseline information. And I think it would really be important to repeat this type of surveys where, you know, more information first is known from the vaccine, and second, that, you know, communication campaigns that will start. So it will be, I think it's very interesting as a starting point, as a baseline for future investigation. So that's, I think, very important. So I will perhaps give the word to Hilde, who is following on the chat, or who would like to ask the next question.
Absolutely. We have a question from Bruno van Pottelsberg, who will ask it himself.
Yes. Is there a microphone issue or is it okay?
Do you hear me now?
Yes.
Yes. Okay.
Yes.
Thank you. So thank you very much. Very interesting presentation. I enjoyed. I actually myself in my bed with the flu, but I listened to you very with a lot of interest. And I have three small questions, but three keywords. The first one is the size of the population, which is characterized by the age group. So the size, the mutual exclusivity of the priorities, and then of course the scientific advisor. So let me explain. For the size, if I am a decision maker or if I have to express my preferences, a key information I would like to know is the size of the target groups. So if it's a small group, then it's very easy to prioritize. The second question is related to the mutual exclusivity, because if you have a large target group, then nothing precludes targeting the target group and then using either the first come, first serve or the lottery, which means that these two methods could be highly effective within a group. And the third remark about scientists, Of course, they should advise policymakers, but we are in a huge national crisis. So the decision should be the policymakers, but with the advice of the general practitioner and of the scientific advisory group. But you need someone to make the allocation process with all the information needed. Thank you very much.
Thanks a lot, Bruno. Thank you for attending despite your health. I know. I imagine how hard it is. I had back pain recently, so I know how it is. So you're right for the size, and that's a very interesting point you're making here, because except NASEM in their strategies allocation that have been discussed for now, where they really tried actually to measure the size of those groups, the other actually national strategies are not really talking in terms of how many people are we talking about here. So obviously in our survey, we did think about all this kind of, let's say refinements, but I was starting to make it even more complicated for the population to understand, the study. But I agree with you, the number actually would matter as well, because again, there would be a question of supply and units being available. And then of course, the aspect of mutual exclusivity, it was as well, in our case, trying to design the DC as well as possible so that we could really elicit the preferences. And so we've been actually playing on some levels and some attributes, but that would have been actually really interesting as well to add slightly more combination of information. But there is always a price to pay when you do this kind of experiment. If it starts becoming too complicated, then you have very biased in terms of who can answer it. But thanks, yeah, all your points are very well taken. About the crisis and dealing with the crisis. So this last question we asked, we were really keen to know whether people, who they were trusting. And so our question was saying, according to you, who should decide? And that was the population only, the scientist, or the government only. Of course, we could have put combinations saying the government guided by the experts, or we could have said as well the population in a kind of democratic debate guiding the government. But we went just with these three groups so that we could have, in a way, an idea on how people were leaning towards a decision more from government, from scientists, or from the population. But you're right, we could have had a much more colorful set of answers, but we didn't. Are there any other questions? Hilde?
Yes, there is, absolutely. From Knut from MSD, who actually asks, how actionable is it to vaccinate the super spreaders? Are we able to already identify them?
So it's a tricky thing, because I guess that actually for a lot of people, super spreaders could be related to age or young people or being people on campuses. But in our questionnaire, we were really not willing actually to talk about young people or partying people, because I guess it could also be related to the living environment of people, where actually they interact with more people, could be even related to their job, the fact that they meet with a lot. So I guess, yeah, it's ideally, knowing really who are the high spreaders is a very difficult way. So I guess, maybe that could be related to contagion zones. And so in that case, some of the strategies, and I know there was a very good piece on that on CEPR as well, is maybe actually looking into vaccinating according to highly contagious zones first, and then going on with the one that are less contagious. But indeed, I don't know. I really don't know how we can, find the high spreaders. Who are they? It's really tricky. Do we count, how often they meet people? Do we use their phone with GPS data? There are different ways actually to do this.
Thank you. Another question was from Matthias Watripon. Do we know whether people wanted vaccination to be compulsory or not? And what do you think then about this, about an optimal policy in this respect?
So no, we don't know. Actually, we didn't ask whether they would accept a compulsory one. We were just asking them whether they would be willing to be vaccinated or not. And so we had, I think, 3/4 of the sample that was saying that they would be vaccinated. And so then in terms of what is the optimal way actually to deal with it, we know that globally for any other types of vaccines, it's very much related to the number of people being vaccinated for things to work. But we know as well that it won't eradicate the disease from the whole population, right? We have vaccines for many other diseases that we still observe, in the population. So myself, I would say that this is a very strong, collective and altruistic choice. And so my suggestion on this would be trying to be as, pedagogical and educational as possible, trying to reduce, the fears of people with vaccination, but actually try to push towards vaccinations so then, everybody can benefit from it. But at the moment, as we were saying, it's very tricky because there might not be one vaccine, but there might be different vaccines. And as Michelle was saying at the very beginning, all those vaccines might be appropriate for different groups. And so I think this kind of uniform campaign would be maybe possible with one unique type of vaccine, which it doesn't look like this is what we're going toward.
Another question, and I will combine the question of Linda Green from the University Hospital in Ghent and Wendel Asuncion, who are asking actually about the profile of your survey respondents, because this, of course, can impact their answers. How did you ensure that conflict of interest was handled well in your sampling methodology? What is the profile and how did they vary in their answers?
So here actually we use a survey company, and so they have actually quite, I think, a large sample of people that they could randomly contact for our studies. And so what we try to do with the conflict of interest aspect is that we try to be as representative as possible of the Belgian populations. So we had people between 18 and 80-year-old. We had people that actually, were representative in terms of gender, in terms of education level, and in terms of provinces in Belgium. Then actually whether some of them, were members of lobbying parties of things related to vaccination, I don't know. I didn't ask them, but I'm hoping that, since we are representative on as many dimensions as those one that I just said, that actually we probably have maybe one outlier, but that won't be the whole 2,000 individual samples. So I'm kind of very, confident on that point.
Okay, thank you. And then Elisabeth Tika asks about first come, first serve strategy. How can this be done while prioritizing? For instance, while one group has priority, the number of the group members is larger than the available number of vaccines. Who will get to be the first to be vaccinated in this particular group? Yeah, so Elisabeth, in this kind of strategies, first come, first served basis, do happen sometimes when allocating goods, that are just in limited availability. In the case of the vaccines here, that would still be quite, I think, a tricky one to put in place. But that could mean that actually, if the vaccine I think that's something that could happen after there's been, for example, the first wave of vaccination. So we could imagine that, for example, when the vaccines are really easily available, and maybe we're talking in 2 or 3 or 5 years, I don't know, then actually that the vaccine is available in a pharmacy, then people could come and buy it, and then we're just facing a story of stock, supply, where actually first come, first served, and when there is no more, then actually there is more production. In the case of really this strategy being the very first one that you put into place, I think it's a tricky one here, because that will be very much related to the environment where people live, and does it go through primary care? Does it go through pharmacy? Does it goes with, I don't know, centers of vaccinations that you can have? So I think, what we need to bear in mind is that in our study, what we tried is to cover all the types of strategies that could exist, but without here considering how easy that would be to put this one in place. And I really think that actually the first come, first served basis, so the market, strategies, would not be actually the most appropriate here, and the most easy as well, to put in place. But we could not ignore that exist, because these are actually ways that sometimes goods are being allocated in the population
when we know that they are rarely available in a limited number.
A clarification from Elizabeth. I mean, what you do when in your priority group there are more members than vaccines. Who get it first?
That's exactly, yeah. Okay, so that's what we were saying earlier. You know, that I think except NASEM in the US, that has really tried actually to think in terms of a tiered approach with phases, where they're starting with 5% of the population, then another 5%, and then they start increasing the numbers. I think nobody has really started thinking this through. And so that's actually really a limit at the moment if you're looking into the priority groups that have been identified by the European Commission in their report or the WHO in their report, where actually the groups are quite large. You know, if you're starting to put everyone with a chronic condition, everyone with actually having an essential work, and then you can have as well the combination of characteristics, you know, so do we vaccinate first, that actually those that have 3 of those, you know, belong to the groups for across all the subgroups? I don't know. So this is more of a practical aspect, but you're totally right. It might be that actually within a priority group, we still need to put a ranking. So we cannot ignore the need for a ranking.
And then a question from Glenn Grauwels. Should we consider people who already had COVID and still have a high level of antibodies the same as people who did not have it yet, or would they have a decreased priority? Would the vaccination priority be dependent on your disease background?
So I'm an economist myself. I'm not really someone who works, you know, with a medical background. My understanding is that actually the immunity level of this kind of disease like COVID means that actually you can get it a second time or a third time. So to me, I don't really know whether actually taking into account this kind of historical experience with COVID, you know, should matter or not. Then, of course, we still know that actually if you've been recently infected, you may be more likely to be protected for a little while than someone who was infected, you know, earlier this year. But I don't know really. I don't really know what would the doctor say, because I guess here, this is as well a question of saying, when you get COVID the second time, you know, can you get it worse than the first time? And I don't know. But if that's the case, then actually that could mean that maybe people who have had COVID could still actually earn a first position. So I guess here, this is really, again, a collaboration maybe with the clinical, you know, aspects. So again, I think all the experts are needed around the table for a multidisciplinary, you know, strategy being guided by multidisciplines, you know, here.
No questions left from the audience. Maybe I have a question for you with respect to people who are now participating in the clinical trials. What do you do with the placebo group, and especially with respect to the long-term follow-up? Where do they get a place in the grouping?
Yeah, I don't know, Hilde. That's a good question. It's true that sometimes, indeed, when the results of a clinical trial are revealed, then sometimes actually the placebo or the control groups, you know, get a kind of special treatment. So could they earn like this, you know, a first place for a vaccine? I don't know, really. That's a good point. I think there are plenty of ethical, you know, aspects behind, where they helped as well the society by being part of a trial. But yeah, I don't know. I think it's a very interesting point that maybe actually philosophers or even just doctors, you know, would be interested to talk about. But I agree with you. I guess, yeah, there's a collective role that was played that actually could earn indeed a faster ticket for vaccine.
Well, on this, if I understood correctly, then the collective responsibility, the people that prefer the super spreaders being vaccinated first over those who were costly to the society, so the economic impact. So collectivity is placed over impact or economic impact. Did you discuss this with, for example, people from KCE with respect also to other vaccines?
So Hilde, it's half of the population. So there is half that actually would put spreaders first, and the other half would put medical, vulnerable. So it's not the whole population, but indeed the high spreaders were upgraded in the second part. And so how, I think your question is maybe how actually I think that our results could be used by policymakers, right? And so what I would say is that obviously there are other dimensions that are much beyond our study, which are part of the limits. But I think what we're doing here, we're just in a way lifting a veil of ignorance of information. Up to now, we've been talking a lot about priority groups, but that was mainly a discussion between experts and governments. So let's say national governments, some discussion as well at international level related to more global supply. And so our study, and I'm sure there are other studies ongoing at the moment in other countries about this, it's just, I think, lifting a veil of ignorance, a veil of lack of information that we had until now on this aspect on two dimensions. The first one being, understanding really what the population think, which could indeed guide the decisions that have been made, and not say, oh, the population says this, we do it, but actually having a better understanding of what the population seems to be accepting or willing to accept, because there are trade-offs here ongoing. And so knowing what are the trade-offs that actually the population is willing to make is useful, I guess, even if in the end the population is not the one making the decision. And I think the second one is also, actually trying to really have just a confirmation that the way, the things are going currently is globally accepted by the population. And so what I think, here there are two levels, could be just an information saying that we take this into account, but another one as well, saying that we are guided towards, making decisions that that actually we know we have collective appreciation for. But then, directly when our work started to be a bit publicized last week, we've been contacted by the Committee on Bioethics. We've been having, some people, contacting us, asking just to read the paper. So it's not, directly saying we will use it, but at least we belong actually to, let's say, the foundation work that actually exists there. And obviously there will be more work in that area coming up.
In any case, thank you for doing this work. It's really valuable. Matthias, our co-director, also has a question. Matthias?
Yes, thank you, Sandy. It's very, very interesting. One question about the design of the study. In a sense, we could argue that comparing, for example, people at risk with so-called super spreaders is a bit of an asymmetric comparison. Well, already it's easier to identify people at risk than super spreaders.
Yeah.
But also people might have a view that somehow super spreaders are people who don't respect the rules, kind of. If you stay alone, you're not a super spreader. Because the other option would have been, for example, targeting teenagers, for example, who, okay, these guys are a bit, they are not like older people. Somehow they like to party more and so on. But we've always been young, huh? So at some level, everybody should have his or her chance to live their youth. On top of that, they are also victims of a kind of education system that doesn't work as well as normal. So people might have more sympathy for teenagers, for example, than for super spreaders. Of course, there are many, many teenagers, and it's not necessarily easy to vaccinate them all. But I wonder why you didn't frame the question also in that respect.
Yeah, so I get your provocative question here. I've been working a lot, on other things where we're talking always about responsibility. Are people responsible of what they do, or can they actually, be put in a context where they couldn't behave differently? And so I'm usually someone who really thinks that there are so many connections sometimes between things you choose and things you control that actually there are more constrained choices than really fully, clear choices. So in terms of high spreaders, you're right. We could think about young people partying, meeting a lot of people, but we could also think about people who are living in very poor housing conditions with plenty of others around them, where actually they don't have, you know, the space to have a big garden and enjoy, you know, private time, where actually they're all together. So I guess we have, you know, a good group as well of people who definitely didn't choose this, and it's a lot of, let's say, socioeconomic context that actually push them towards being in a crowded setting. Then, you know, trying really to say who are those people and giving very precise examples in our study. We did talk a lot about it. So for example, I could have said, when we're talking about people that would cost a lot to the society, I could have said, we're talking here about the big CEO of that company being sick, or we're talking here, you know, the big cardiologist, you know, that costs more and that costs less. So in the end, we decided we're just talking about a cost per day to society without saying which job we were thinking about. And then in terms of spreaders, that was the same. We were actually saying someone that on average can contaminate 10 people, or on average could contaminate only one person. And so that was really a choice we were making, because we didn't want, you know, to find in a way, or even almost to guide people to answer, you know, with what we thought could be the reason explaining this. And so getting this kind of, let's say, global frame is actually leaving anyone reading the questionnaire interpreting it its way. But you're right, in the end, since it's very normative according to what everyone subjectively will think about the question, in the end, I don't know what they think. I don't know if actually they decided to vaccinate the high spreaders because actually they were living in Louvain and we heard so much about actually students continuing partying, or whether it's because they were living in a very poor environment where actually, you know, they were in a big building with everybody, you know, interacting in the corridors. So you're right. I don't really know what people interpreted from the questionnaire. But in any case, there was a real, I think, open choice that we made, that we could put in essential workers, both, you know, the garbage collectors and the doctors, without really saying which one we meant.
Thank you.
Thank you. The next question comes from Michel.
Yes, Sandy, thinking again at your two clusters and hearing what I'm hearing more and more now that the vaccines are coming. So people say, okay, that's great, but you know, I don't want to, I don't want to be among the first. I first want to see what will happen. So one way to translate this is say, wow, let's focus on those who spread the virus, and I will wait. Actually, perhaps I will even not be needed in. The other cluster might be related to the fact that people don't consider themselves as so vulnerable. So it's, well, let's start with, you know, the old people and other people who are very sick. I'm young and well, and okay, again, it's a way to wait a bit. So I was just wondering, in your population, perhaps you said it and I missed it, but what was the percentage of people who might be considered at high risk?
So in the survey, we had 39% of the population who told us that actually they were considering themselves at risk. So so we had, you know, either people that were saying because they were older. So that was another interesting point that we made. We asked them, do you consider yourself at risk for COVID? And then we asked them why, because we didn't want actually to force people, for example, older, to tell us that they were at risk, because maybe they didn't think they were. So, and then we were asking why. So some of them said they were at risk because they had a comorbidity, because they were older, because actually some of them said they were obese or they were smokers. So they were actually all of them self-assessing whether they were at risk or not. The other point you're making about choosing the vaccination according to your own characteristic, that's the fact is that for our clusters, it was not related actually to their own characteristics. So neither people were more at risk decided actually to vaccinate first dose are more at risk, neither if they were not. So that was not actually the belonging to each clusters was not related to this kind of characteristics. It was more related actually to their attitudes towards vaccination, the experience with COVID around them, and the languages as well.
And what about the cluster in favor of the super spreaders?
The same. The belonging to the membership was, yeah, because we're comparing them like this. So that's an interesting thing, is that it was not really led by actually self-interest. And so I think that's interesting. But I guess you're right as well in terms of people maybe deciding that they prefer the others to be vaccinated first than actually themselves. So the fact that it's not related to their own characteristic could explain that actually they were more thinking for society as a whole, for others that needs them, but not including themselves.
Thank you very much.
I'm just looking, there are no questions left from the audience. I don't know, maybe Michel, you want to conclude?
Well, I think that my conclusion will be rather short. I think that the work we just heard today is extremely important. I think that probably one of the most important challenges we are facing now is really how we will explain and possibly convince the population, and also explain the decisions that have to be taken, very difficult decisions, because different vaccines will come at different times and in different quantities. So it will be a real challenge for decision makers. And I really think that studies like the one you just conducted are extremely important to help and to take the right decision, and not to be back in the situation that we had with the H1N1 vaccine. And I think that it would be interesting to see whether there are data available about how, you know, public preferences were at the time of this H1N1 pandemic, which finally didn't require mass vaccination. So thank you so much, Sandy, and I really hope that we keep in touch in the near future. Thank you so much, and thank you for all those who attended our I3h seminar. More to come.
Absolutely, and maybe just very briefly, because we already had questions from the audience asking for your paper, the slides and the material, the recordings will be shared online as from tomorrow morning onwards. Thank you, Sandy, for being with us.
The paper is available online freely, so people can look at it. But yeah, thanks.